Okay, here's the lecture on the cardiovascular system pathology that concludes our lectures on the cardiovascular system. What we need to do in these slides is cover Starling's law of the heart again, just so you understand the relevance of it, and cover the four major problems that we can encounter with the cardiovascular system, including hypertension, atherosclerosis, coronary heart disease, and heart failure. When we're asking what we refer to as cardiovascular disease, you have to remember that CVD is an umbrella term that defines any condition that's affecting the heart or the vasculature. The most common ones include hypertension, which is high blood pressure, heart failure, which is the condition where the heart fails to act effectively as a pump, coronary heart disease leading to heart attack, or cerebrovascular disease, which leads to stroke. Along with these four, we also have peripheral vascular disease and rheumatic heart disease and congenital heart disease. If you're not sure of the difference between a congenital and non-congenital condition, congenital means that you're born with it. Finally, the cardiomyopathies are also grouped as cardiovascular disease under this umbrella term. This pie chart shows the proportion of deaths in men by cause in 2012. The key message I need you to take from this slide is how many deaths were due to cardiovascular disease in one form or another. So if you add up the percentages for coronary heart disease, stroke and other CVD, you'll find that cardiovascular disease in one form or another was responsible for 36% of the deaths in men in 2012. If you compare that to the cancers, which are responsible for 30%, you realise why cardiovascular disease is such a huge strain on the healthcare systems in all the countries. If we actually compare that previous pie chart to this is the same chart, so percentage of deaths by cause in women this time. If you look at that, the first thing you should note is that the parts of the pie chart for coronary heart disease, stroke and other cardiovascular disease are significantly higher than those for men. In 2012, 43% of women's deaths were due to a form of CVD. That's a considerable concern because it shows quite a change over the past few decades. In previous years, heart disease and cardiovascular disorders were considered to be more affecting men than women. However, with change in lifestyles and change in practices with food and alcohol consumption particularly, we're seeing a change in this and we're starting to see more women affected as well. If you compare women, 43% of deaths due to CVD. If you compare that to the cancers, only 23% of deaths in women were due to cancer in 2012. When you remember about the physiological variables from when we did previous slides, remember that the actual constant value is unobtainable. You always have a distribution around a particular value. So the actual value itself isn't such a concern as long as the body can maintain around a set variable. In distribution of blood pressure, we consider blood pressure distribution to be unimodal. So any distinction we make between normal blood pressure and a high or abnormal blood pressure is purely arbitrary. This chart shows the number of men and their diastolic blood pressures to show you an idea of what's happening. If you look at this distribution, you'll find it's a normal distribution, the most common of the modal values being between 75 and 85. That's for your diastolic blood pressure. So if you remember, blood pressure is shown as systolic over diastolic, 120 millimetres of mercury over 80. You'll see that the vast majority of people are around about that central point, with people going off to the extremes at both ends. Hypertension is defined as the level of blood pressure above which investigation and treatment is likely to do more good than it is to do harm. So again, it's an arbitrary thing and it's quite difficult to actually determine what we mean by hypertension. The diagnosis and symptoms for hypertension. In order to diagnose the condition, we need to have a blood pressure over 140 over 90 millimetres of mercury that is sustained over an extended period of time. It's quite possible for your blood pressure to go very high in times of stress or after exercise. The critical point here is that it remains high and doesn't come down again. There are virtually non-existent recognisable physical symptoms for high blood pressure. The vast majority of patients aren't aware that their blood pressure is on the high side. Some patients may experience dizziness, headaches or blurred vision, but not all. In 90% of adult cases, essential hypertension exists, which is where we have hypertension of an unknown cause. The remaining 10% show secondary causes as a result of renal damage or endocrine disorders. Hypertension itself is a problem because it increases the risk of coronary heart disease, stroke, heart failure, and peripheral vascular disease and atherosclerosis disease. So in itself, it has excessive problems. As the high blood pressure exists, you're going to see more damage likely to the glomerulus of the kidney. As a result of kidney damage, you're then going to cause more hypertension. If you need to remind yourself of how the kidney regulates blood pressure, look at the renal system lecture and look back at hormones where we did about the renin, angiotensin, aldosterone pathway. The risk factors for developing hypertension can range from the usual suspects, so lifestyle choice. Tobacco usage, physical inactivity and a poor diet are all major risk factors. People tend to live longer now than they did in previous generations, which means we're exposed to the risk for longer, increasing our likelihood of developing hypertension. And there are new risk factors that we're identifying. In previous generations, people from low or middle income countries who developed infections and low birth weight infants tended not to survive. With much improved medical care and management now, the babies that are very low weight and those who are recovering from infections do survive. However, they seem to have a heightened risk of developing hypertension in later life. Another key risk factor for hypertension is obstructive sleep apnea. This is a situation where during sleep the muscles of the throat relax, blocking the airway and interrupting the flow of oxygen. It causes the patient to start to rouse from sleep. As they do so, their airway reopens and they start breathing normally again. Some of these risk factors, such as lifestyle, blood pressure, weight management and activity, can all be modified. We can also modify for patients who have diabetes, who have a significant increased risk of hypertension, by ensuring that they maintain their insulin as they should and they try to maintain their blood glucose at a safe level. The main problem here is that risk factors synergise. So for any cardiovascular disease, if you have hypertension, you have an increased risk. In this case, approximately 3 times the risk of developing a form of cardiovascular disease. Raised serum cholesterol level gives you a 4 times increased risk. Smoking is a 1.6 times risk. If, however, you smoke and have raised serum blood cholesterol levels, you have a ×6 increase in your risk factors. If you add into that you have a smoker with raised serum cholesterol who has hypertension, that risk multiplies up to multiples of 16. As a result of that, you have a much heightened risk of developing any form of cardiovascular disease. Although we don't necessarily know how to control hypertension, or we may not be effective in controlling it, particularly in patients with no known cause, modifying lifestyle choices can reduce the smoking and can also bring down serum cholesterol. So there are ways of managing risk. In hypertension, we see a significantly elevated total peripheral resistance. This can be due to the narrowing of the arteries due to vasoconstriction, and it can be due to structural narrowing of the arteries, where the tissue in the endothelium of the artery is actually growing and we're seeing vascular remodelling occurring. This growth and remodelling can change the structure of the arteries and make them narrower, and that can itself cause for an increase in the total peripheral resistance. Remember that blood pressure is continuously distributed in a population, and we have no threshold for blood pressure risk. So if we look at systolic blood pressure and risk in a population, here we're looking at a population, populating distribution is on the left axis, systolic blood pressure on the horizontal, and stroke mortality per 1,000 person years on the right hand axis. If you look at the green bars first to look at the systolic blood pressure, and remember we take nominally normal value of 120/80 as being an average standard level for blood pressure. If you look at that point, you can see that you still have a risk of stroke mortality, but it's very low. Remembering that hypertension is deemed to be over 140 millimetres of mercury as a systolic blood pressure that is sustained, if you move to that point on the chart, you can see a rate of rise risk has increased here. So what we're seeing is an increased risk of developing a stroke and dying from it as you're increasing the systolic blood pressure. If you look at these radiographs up top first, on the left we have a normal heart, so normotensive. On the right we're looking at a hypertensive heart. The first thing to note on the left diagram is where the heart is. It's situated exactly where it should be, below the sternum, between the lungs and the thoracic cavity. If you look over to the right hand radiograph, you can see that the shadow showing where the heart is enlarged considerably. Particularly the left side of the heart has become absolutely massive. It's pushing the lung out of the way and it's starting to make that radiograph look really weird. If you look down at the physiological hearts underneath, the normotensive heart shows the left ventricle. At this point the heart has been rotated so you can see it, and you can see the set width there. If you look at the hypertensive heart, you see a massive increase in the muscle mass of the left ventricle wall and a corresponding decrease in the chamber size. So that's there to try and adapt to this increase in blood pressure that is happening consistently, but ultimately it causes problems with the heart. Treatment strategies in hypertension are varied. Remember that key equation from before of mean arterial pressure is cardiac output multiplied by total peripheral resistance. So first of all we can use beta blockers which reduce the cardiac output via the beta adrenoreceptors. Secondly, we could use diuretics. These work to reduce the blood volume. Question mark by the kidney, this is actually an incorrect assumption, but we do manage to reduce the blood volume. ACE inhibitors or AT1 antagonists are also effective. They cause vasodilation by blocking angiotensin II, which in turn allows those blood vessels to dilate. That reduces the total peripheral resistance. We can also cause vasodilation by blocking calcium entry with calcium channel blockers. Again, that will affect the TPR and will reduce the blood pressure. Alternatively, instead of vasodilation directly, we can inhibit vasoconstriction via alpha adrenoreceptors by using alpha blocking drugs. We'll cover far more of this in stage 4. Alan Richardson will cover a lot on the diuretics in coming stages of the course with you. I mentioned atherosclerosis earlier in the lecture. Atherosclerosis is an inflammatory disease and is actually the most important disease that we see in humans in the arteries. Derives from the Greek word athera to mean gruel or porridge, and sclerosis, which means hardness. So literally what is happening is we're seeing a hardening deposit forming on the inside of the artery. We have a predilection for this at the branch points of arteries, so very similar to where the blood flows. If you remember talking about blood flow and sickle cell disease, that branch point in the arteries, the blood is slowing down. The same applies here for the atherosclerosis, so you're more likely to get deposition of these plaques at these branch points. The plaques themselves are made of cholesterol and lipids. So if we have a look at the light microscopy scans at the bottom, on the left is a normal artery. So you can see the normal vasculature there, nice wide open lumen, and the inner surface of the artery is relatively smooth. If you look across to the obstructed artery, you can see that the lumen is half the size it was, so you've got a partial obstruction here. The atherosclerotic plaque is that large mass on the right hand side of the artery, starting to occlude that lumen. That means that your peripheral resistance will go up and blood flow through that artery will be compromised. There are 4 parts of the puzzle with atherosclerosis. The first is stenosis, which is a gradual loss of luminal diameter leading to a critical reduction in blood flow. If this happens, say, in the heart, then you start to starve the heart muscle of oxygen. Rupture will lead to a sudden thrombosis and or embolism. So this is a blood clot forming where it shouldn't do. Because you've ruptured that atherosclerotic plaque, you've damaged the endothelium of the blood vessel. That will then trigger the normal clotting cascade, leading to a thrombosis. So the thrombosis itself may occur and may actually lead to a sudden vascular occlusion, which completely blocks the artery. And the embolism is dislodgement of solid material, for example a thrombus, so it then gets into the arterial circulation and leading to an arterial occlusion at a different site, which could be in the brain, it could be in the lungs, it could be in the tissues. The effect of stenosis, thrombosis or embolism is all the same. Basically, you're blocking fluid flow through that artery, so you're starving tissues further down through that pathway of enough blood and enough oxygen. This is ischemia, so insufficient blood supply will lead to this. It leads to cellular dysfunction and extreme pain, so for example, damage to the heart, damage to the brain or damage to the legs. Often experienced as pain on exertion. So if you're experiencing angina pectoris, this is where you're having pain in the heart as a result of insufficient blood flow to that heart muscle. Will only actually damage the tissue further downstream from where the block is. I mentioned cholesterol as being a risk factor for high blood pressure. It's also very important in atherosclerosis, as cholesterol and other fats can't dissolve in the blood, so they're transported to and from cells in special carriers called lipoproteins. The most important of the lipoproteins are low-density lipoprotein, or LDL, and high-density lipoprotein, HDL. You'll hear people talk about good fats and bad fats. This is the point where we explain about that. The LDL, low-density lipoproteins, contribute to plaque formation and are pro-inflammatory, so in those cases they are a problem, whereas high-density lipoproteins are anti-inflammatory. So we want to have a good balance of these in the blood. We have both HDL and LDL in the normal situations. We just want HDL to predominate. There are various ways we can treat atherosclerosis. Once it's actually happened and you have a block in the artery, you can help to reduce any further effects. You can take statins, for example, which are lipid-lowering drugs, and there's been an awful lot of them in the media over the last few years. By reducing hepatic cholesterol synthesis, you also manage to lower intracellular cholesterol, which stimulates the upregulation of LDL receptors and increases the uptake of non-HDL particles from the systemic circulation. By doing that and removing the LDL cholesterol from the system, you're removing that increased risk and hopefully maintaining the balance of high level of HDL to low level of LDL in the circulation. If you want to look just for a moment at the coronary blood vessels, so on the left we see the anterior view of the coronary arteries, on the right we see the anterior view of the coronary veins. I don't need you to know the names, but I do need you to be aware of what happens with these blood vessels. So as you can see over on the left, you have quite a considerable amount of blood vessels going across the surface of the heart and the ventricles particularly. You have branches coming from various arteries, the main arteries of the heart. So you have branches coming from the aorta through the left coronary into the left coronary artery. On the side with the veins, again, matching where the arteries are. You don't need to worry about the names of the veins. Just be aware that they cover the entire of the heart. This particular diagram shows false staining, where they've actually injected a stained resin in to stain up the blood vessels, and you can see them more clearly. Again, don't worry about the names, but be aware that the veins and the arteries coming down across the heart cover the entire surface of the heart. You have a lot of capillaries in there as well, ensuring the entire cardiac muscle is supplied with oxygen and nutrients as required. If you remember the cardiac cycle, I kept banging on about how you only get blood flow through the heart during the diastole period. That's what's shown here. So we have pressure in kilopascals on the left, time on the lower axis, and this point showing you 0.5 of a second. During systole, we see an increase in pressure in the ventricles and an increase in pressure in the aorta, a very slow increase in pressure in the atria. During the diastolic period, the aortic pressure actually has a little peak and then goes down. The ventricular pressure drops off rapidly and atrium pressure also drops off, and that is the window for coronary blood flow. As soon as the heart then goes into the next systolic contraction, the muscle is contracting, therefore you're not going to get blood flow through those vessels at that point. Coronary heart disease can lead ultimately to myocardial ischemia, which is where we are lack of oxygen to the heart muscle. Myo means muscle, cardial is heart, and ischemia simply means lack of oxygen. So if you look at the diagram, we have a blocked blood supply in the coronary artery. Downstream of that, where you're going to get a lack of blood flow, all the muscle that would be fed by that vessel is starting to become significantly damaged. We treat coronary heart disease in various ways. It depends on the cause. If atherosclerosis of the coronary arteries has led to myocardial ischemia, lifestyle changes and medications are useful to maintain the situation as it is. Medications to ease the pain, to dilate the vessels and allow increased blood flow. Lifestyle changes to ensure that that blockage does not get any worse. It's a lifelong management. It is not something that goes away and comes back. Ultimately, if it is a very severe block, we can go in for surgery, and you can have either coronary angioplasty or a balloon angioplasty or a bypass surgery. So in balloon angioplasty, what happens is a very narrow catheter with the balloon on the end is inserted into the obstructive area of the artery. If you look at the diagram at the top, you see the atherosclerotic plaque. In this case it's on both sides, narrowed lumen of the artery, and this is in the coronary artery itself. So you're inserting a catheter into the blood vessels of the heart itself. The balloon is then inflated, which stretches the arterial wall and squashes the atherosclerotic plaque down. Once you've widened the lumen, you can then remove the balloon after it's deflated and take out the catheter. This is called percutaneous transluminal coronary angioplasty, or PTCA. Alternatively, you can have a stent put into place to help hold that artery open. So on the diagram on the left, you see this tiny metal network. That's the stent. It literally is a little mesh. It's inserted again via a catheter into the occluded part of the artery. The artery is then widened to squash down any plaques and release any block, and the stent is put into place to help hold that artery open. If you have a look at the angiogram on the right, you can actually see where the stent is in place, in this case in the circumflex artery of the heart. Alternatively, a relatively common surgery now is bypass surgery. This is a coronary artery bypass graft that we're seeing here, and effectively what's happened is that blood vessel, if you see the square that's been magnified, has an occlusion in, and that's the atherosclerotic plaque. What you do at that point is physically remove a piece of blood vessel from elsewhere and physically graft it in. So it's now going from the ascending aorta and it's going to the point downstream from where that block has occurred. So you're basically transplanting that piece of tissue to get around the block. It's like putting another motorway as a bypass instead of having to go on the same road. You can have single bypass, double bypass or triple bypass. If it's a triple bypass, you're having to use 3 grafts to move past 3 blocks. Double bypass is 2. If you go into heart failure, this is a pathophysiological state where an abnormality of the cardiac function means that the heart is no longer able to pump blood effectively enough to actually maintain the requirements for your metabolizing tissues. There are several causes. For example, arrhythmias, so where the heartbeat isn't working correctly and the atria and ventricles are not contracting in rhythm. Valve disease, which means again that the heart is less effective. Pericardial disease, congenital heart disease and myocardial disease. Hypertension increases the risk of heart failure significantly. I mentioned we had to cover Starling's law again, and this is why. So you have a normal heart shown in red. Same as before, you have stroke volume in millilitres up on one axis against end diastolic ventricular volume on the horizontal axis. As you increase the end diastolic volume, the stroke volume increases. If you have somebody whose heart is starting to fail, if you look on the bottom line, for any given end diastolic ventricular volume, the stroke volume is considerably lower than that for a normal heart. If you give sympathetic stimulation in one form or another to that failing heart, you're encouraging it to beat more rhythmically, you're encouraging it to beat with greater force. So you compensate a little bit, but it's still much lower than for a normal heart. Heart failure, its prevalence is around about 1 to 3% of the population and is 10% in the population over 75 years. We see an incidence of 0.5 to 1.5% per annum, and the prognosis is far worse than cancer. Generally speaking, for heart failure, 50% of patients will be dead within 3 years. In the community, the mean age is 76 years, and there's a ratio of 50-50 men to women affected. It puts a huge strain on the NHS and on other healthcare organisations such as GPs and pharmacists. 5% of acute hospital admissions are due to heart failure, and 10% of bed occupancy is due to patients suffering heart failure. Of those patients, there's a 40% readmission rate in any 1 year, and 40% of hospital admission patients will be dead within 1 year. Approximately 2% of the total UK health budget is actually functioning on trying to maintain treatment and care for those with heart failure, so it's a massive problem for the NHS. The symptoms are fairly vague, so shortness of breath on exercise, easily fatigued to the point of exhaustion, not just a bit tired but utterly exhausted. Palpitations, dizziness and fainting are all signs that the heart isn't working as it should be. And of course the classic sign of angina leading to chest discomfort, tightness and pain. Many patients will suffer angina without suffering heart failure, that all of these symptoms are non-specific. I've mentioned that the prognosis for patients with heart failure is very poor. Death can come from a variety of reasons, including progression of heart failure. So the myocardial wall comes under increasing stress, and we see an increase in retention of sodium in the water, which leads to edema and increases the pressure on the vessels. Sudden death syndrome is a condition where it's an acute coronary event which is more often than not undiagnosed. So a person appears completely healthy, quite often athletic, and you have an opportunistic arrhythmia, which is where the heart suddenly starts to beat inaccurately. Instead of having a nice rhythmic contraction of the atria and then the ventricles, you see this arrhythmia coming in. Quite often that leads to sudden heart failure, which results in death. Heart failure itself can lead to a myocardial infarction or other cardiovascular events such as a stroke, depending on how badly damaged the tissues and the vessels actually are. So in summary for this lecture, we've covered Starling's law of the heart and why it's important, and the 4 major conditions that affect patients with cardiovascular disease such as hypertension, atherosclerosis, congenital heart disease and heart failure. If you need any more help with any of this or any of the other CVS lectures, please don't hesitate to contact me.